Hello, everyone. Thank you so much for tuning in. We are very pleased, indeed, to be launching this rather exceptional event. This is a first. Here we are for our European conference on Alzheimer's. Let's talk about it, and we're very pleased to welcome two great experts with Professor Antoine Piau, the new Medical Director and Ethics Director and Health Innovation Director at the Clariane Group. Hello, Antoine. He's a geriatrician and a professor at the Toulouse University Hospital. We are also very pleased to welcome Professor Bruno Dubois, who will make a presentation about this complex disease. Professor Bruno Dubois is a neurologist, is a major expert in Alzheimer's and known around the world. All right, so I suggest we get started. Antoine, over to you for your words of introduction. Thank you very much, Marianne. And indeed, I am very pleased to be welcoming the group here to this inaugural conference. And indeed, this is the first of a major campaign. And tomorrow, on the Clariane.com website, there will be 10 short videos made available to you. What's the objective here? The idea is to target the nursing staff and also caregivers to better understand the diseases, to better support them as they try to support their loved ones and their patients, and also to give you a voice, and to raise awareness and understanding of the disease. All countries were engaged. Thank you to each and every one of you for your engagement. Many open door events, many talks and discussions organized. So thank you for your support and engagement throughout the campaign and also day to day. So welcome to Bruno Dubois, Professor Bruno Dubois, for his presentation. When you understand something better, you no longer suffer so much. So thank you very much indeed for giving me the opportunity to speak to you about Alzheimer's disease. AD. Right. Well, as a matter of fact, I had published a book about this disease 3 years ago, and I had entitled it "The Truth About the Disease of the Century." Why did I say that this was the disease of the century indeed? Well, this is a disease that is not owed to aging, but rather related to aging. So longer life expectancy is something that we can say that we're very lucky to have as Western societies, but it can also lead to such kinds of diseases. At the start of the century, average life expectancy was 40 years, and now it amounts to 85 years. And if you have a daughter who's born today, her life expectancy will be 95 years, i.e., she will be at a risk of developing Alzheimer's disease 40 times out of 100. So Alzheimer's is the disease of the century and is also a brain disease described for the first time in 1906 by Alois Alzheimer. And at the very start, this is a disease that was only prevalent amongst younger patients. And indeed, the very first individual that was described as suffering with Alzheimer's was 52. This was a pre-senile disease, and it was a rare disease. And then in 1976, it was decided that it should be associated with another disease, senile dementia. And in fact, both diseases are the same, with the same histological lesions, brain lesions, so on and so forth. So Alzheimer's disease was then turned into a very frequent disease, since senile dementia was thereby associated with it. And I think that that is a good thing. Then there's an exponential growth in the disease in our societies. It is estimated that in France there are roughly 1.3 million people suffering from AD in France, and so it has now turned into a major health issue due to population aging. in our developed countries. And I really want you to understand the reason why this is a tsunami we're looking at. Our house is growing older, and we're looking elsewhere. On this slide here, you have the countries where 20% of the population is aged 60 and up. That was in 2012. Here you have North America, Europe, Australia, and Japan. Now let's take a look at what will happen in 2050. And here, this time, you can see that all countries are concerned, apart from Africa and India. All of these countries will be confronted with the issue of population aging, and indeed we're no longer talking about 20%, but 30% of population aged 60 and up. So as you'll have understood, this is a disease of the future for our societies. But it is a brain disease, first and foremost described by Alzheimer himself, who met this patient, August D. He observed her, and he showed that all of the disorders and impairments, cognitive impairments, behavior disorders, psychiatric disorders of this individual were related to the two lesions he described in the brain of that patient, i.e. amyloid lesions and tau lesions. These are the only two medical terms I will talk to you about today. So tau lesions and amyloid lesions. And he showed that these cognitive and behavioral disorders were associated with these lesions for the very first time. He showed that brain and mental impairments and disorders were related with lesions in the brain cortex. So 1902, a very important date indeed. Now, on the basis of this, the diagnosis for this disease was based on the concept of dementia syndrome. In other words, it was a two-step process for diagnosis. First of all, identify the dementia syndrome. What is dementia? This is the unfortunate medical term. We're not saying that these people are crazy. We're just saying that this is a disorder which will have an impact on their behavior and on their capacities. These are people who will no longer be able to manage their budget, take transportation, feed themselves on their own. So this is a true loss of autonomy we are talking about here. So back then, the first step was to first identify this dementia, and then, on the basis of a number of arguments, would be gone through with a list of the a number of tests, psychological tests, neuroimaging as well, to rule out, for example, a tumor, and also to identify a number of signs which may point towards the disease. So for example, an atrophy of hippocampus. So this was an exclusion approach to identify an Alzheimer's type of dementia. And then, over the past 20 years, there has been tremendous progress. I would say that this is the neurological disease that we have progressed the most with. This progress is tremendous. So let me talk to you about the natural history of the disease. It is known, and that's very important. We know the natural history of this disease. For so long, it was said that this was a heterogeneous disease, and that is not true. As you can see on the left, this disease starts with a lesion in the hippocampus, a small region in the brain, and for the longest time, this was a disease that was only limited to the hippocampus. And then, as time goes by, these lesions will spread out from the hippocampus to other regions in the brain. And then it will actually spread to the entire brain. So there are two different steps here. First of all, for a long time, there will be isolated memory losses. That's the prodromal phase or stage. That may last up to 10 years, maybe more. And then, at a certain stage, due to these lesions spreading to the rest of the brain, there will be other signs showing up. For example, apathy, judgment impairment, language impairments, issues in relation with recognizing certain people, certain objects, psychiatric problems. And so all of these cognitive signs added up to behavioral impairments will have an impact on these individuals' autonomy, and that's when you enter the dementia stage. So there's the prodromal stage followed by the dementia stage. The prodromal stage is characterized by memory impairment, of course, and this might lead to certain people wondering, right, is this me? Because from a certain age, people tend to suffer from memory losses. But as you'll see, this is a very complex issue. Let me speak to you about a patient that I had who is 70 years old, and she told me, I can no longer count mentally. I keep on forgetting what I have just done. I might enter a room without knowing what I was looking for there. I will give an appointment with to my daughter, and I'll tell her I'm on my way. Then I don't go there, and then she calls me back, and I'll have completely forgotten about the appointment we were supposed to have. I no longer recognize a document that I'll have drafted myself. I can no longer remember that what I have done the day before. I can no longer remember if I have answered a letter or not. But as a matter of fact, she did not have any memory disorder as such. So I'm forgetting about everything. Is this serious, doctor? You might say that memory complaints are not necessarily related with an actual memory deficit. We had asked patients, as part of a study, to assess their own memory. And on this graph, if you take a look at the red line, you will see that MMS was 29 out of 30. This is a thermometer of cognitive functions. Usually you're around 28 or 29. I would say that everyone around us here will be around 29 or 28. So these people here had an MMS score of 29 out of 30, but they complained so much about memory. And then you have patients who are actually suffering from AD, and as you can see here, their capacities, memory capacities, are truly affected, and yet they did not have any complaint with regards to their memory. And so a few years ago, I actually said that the more you complain about your memory, the less you're likely to suffer from AD. And usually that makes people at ease. People are quite reassured because complaining about your own memory is only very natural. So that's a standard. So many people complain about this. By complaining about your memory, it doesn't mean that you're going to have memory disorder, but just that you have issues recording certain types of information. It's more of an attention deficit rather than anything else. So here you have attention on the one hand, and then once you have your vision, your hearing, that's mobilized, that information is sent, just like a rugby ball, to the hippocampus. So that's the door, basically, opening to the brain bank where information will be stored. If information is not properly entered, then nothing will come to the brain. Second case, you might pay very great attention to the information. Information is sent to the hippocampus, but hippocampus might be broken, so that information will not reach the brain. Third case, that information is properly received and stored, but you need to be in a situation to retrieve that information. So as you can see, there are various ways of complaining about your memory, and what we're interested in is when the hippocampus is indeed impaired, so when information is not properly stored in the brain. Third, and this is a recent development, the lesions related with the disease, those lesions which we can just have access to with a post-mortem examination. Now we can have a look at them when the individual is still alive, thanks to this PET scan technology. And here you have the reading grid. Really, let me run you through this. At the very bottom, it's blue. It's called no lesions, and upwards, when it turns red, it means that there are many lesions. And on the very left, as you can see, this is someone, an individual who is not suffering from AD, and on the right, someone who has many lesions in the frontal region, particularly, so someone with AD. There are tau lesions, amyloid lesions, and we actually now have markers which we can have in vivo. This very evening, I may go to a hospital and undergo this examination. I'll be injected with a substance, and that's how we'll know whether I suffer from AD or not with these biomarkers. Moreover, and this is something that we can do today, such PET examinations are quite complex, so you can also proceed otherwise. With a lumbar puncture, you can have access to the very same kind of information, knowing the concentration of amyloid and tau lesions in the brains of our patients. Fourth recent development, we now have medications and drugs which are under development and which are efficient. This is a very interesting graph here with the reduction of concentration of lesions in the brain thanks to these drugs. We measured the concentration of amyloid liquid in the brain of these patients at the start of the study. And a year and a half onwards, when you go through the very same examination, you realize that 80% of lesions have disappeared. So now we have drugs which can destroy up to 80% of AD lesions. Incredible results, right? So you could say that they cleanse amyloid lesions in the brain. Unfortunately, such drugs did not have any traction on the symptoms of advanced individuals. And that's why the prodromal stage is so important. Thanks to that stage, we're able to study such drugs on earlier patients. This is a study which was released last year, and here we can see that there is a medication slowing down the onset of the disease. So this first result is very important. You can see that you have an impact on lesions, and you can also here have an impact on symptoms. A milestone indeed. This drug was authorized in the US, and now the file has been submitted in January of this year in Europe, and will have the results of this process in January of next year. Moreover, lesions appear before symptoms. And we can see that 10 or 15 years before the actual symptoms, these markers are being modified before the symptoms appear. So 15 years beforehand, you can see an increase in amyloid lesions in the brain, or of tau lesions in CSF. So I said that there are various stages in dementia, and for sick patients, you can actually identify the disease at the prodromal stage. This is something we can do now, but perhaps also we can also target normal individuals with no cognitive disorders, but who have these biomarkers. And these three stages have in common these biomarkers. This is a preclinical stage that's very interesting. Many research studies are being undertaken on older, normal individuals with positive biomarkers. Why? Well, that is because, as I said, drugs can clean up lesions. So if you have normal individuals with lesions, perhaps we can clean up these lesions and so slow the onset of the disease. On top of this, we've identified protective factors in relation with cognitive aging. So for these at-risk individuals with lesions, perhaps we can prevent cognitive aging. Here you have a list of a number of prevention factors, such as walking, healthy diet, social interactions, so on and so forth. So as you can see, for older people, positive biomarkers are key. However, as we have seen at the Salpêtrière Hospital with our studies, one must be very much aware of the fact that having these positive biomarkers might not be enough to determine the AD continuum. In other words, these biomarkers are essential, but they might not be enough. Our study was published in the Lancet. It was undertaken over 7 years with individuals who were aged, who had positive amyloid lesions, but they were normal. 88 of these individuals had lesions, and out of these 88 with positive amyloid lesions, only 16 actually developed AD. In other words, you might have these lesions, but you may not necessarily suffer from AD later on. Why? Because there are compensation mechanisms that enter into play. And I'm not saying that this one in particular is responsible for it all, but this is very interesting nonetheless. Up on this graph, you can see the power ratio changes, REEG. This is an average, and of these 3 successive examinations over 3 consecutive years, there is no change in REEG. These are stable patients, and over time they modified their electric and power activity as if the brain was able to modify a number of parameters to maintain the same functions, whilst in fact there are structural alterations. So that's what I mean by compensation mechanism, and that's the whole cerebral resilience concept that we introduced. The brain is able to modify the way it works to maintain its functions. So that's what I wanted to say in a few minutes. Obviously, this is a bird's eye view of the situation, but as part of this overview, I tried to explain how important Alzheimer's is for our societies due to population aging. And also I wanted to show you that over the past 20 years, there have been many studies undertaken on the matter, and I would say that there will be lots of new data on the disease thanks to these drugs, which are being released to slow the onset of the disease, and also due to biomarkers. We can now identify such biomarkers in the blood. So all of this data has been presented as part of these short videos we've been working on for the past 6 months, and you'll be able to have access to these short videos as of tomorrow on the Clariane.com website. Thank you for your attention.
Thank you, Professor Dubois, for this very interesting presentation. I hope all the people who are connected enjoyed it. And as Professor Dubois said, you will find all the elements in the videos that will be made available tomorrow on Clariane's website. So now I suggest we move on to a Q&A session, questions that were asked by different countries in the group. Unfortunately, we won't have enough time to address them all, but we've chosen a few. First question, maybe Professor Piau, you can answer it. Following question: certain behaviors raise ethical questions for teams. How should we react? It's not an easy answer. I will take an example that will speak to field staff. Let's say we have a patient with AD who has behavioral disorders, who's disorientated, who's wandering, and who's disturbing other patients. So there are two imperatives here. First, relieve the patient who may be anxious and who is wandering or maybe not do anything, but also ensuring the quality of life of other residents. And so when we have two contradictory imperatives, the only thing we can do is hold a collective discussion with everybody. So talking about this patient in this particular context. So we should discuss in a team, also define a collective position and inform the family and get the patient's informed consent when possible, or that of their caregivers, family caregivers. In each situation, we might decide to administer drug therapy or non-drug therapy. We have experts in very different fields who can work together. That's why it's important to have a network of professionals. And there are also secured units, so-called adapted units of daycare. And so every home should be able to answer the specific needs. Second question, maybe for Professor Dubois, about diagnosis, and three questions in one. Following question, should the disease be systematically diagnosed and announced to patients and families? That's the first question. Second question, establishing a diagnosis, does it lead to better management of the disease? And third question, once a diagnosis has been made, can progression of the disease be slowed down? You've already addressed this point, Bruno. Yes, a diagnosis should be established. There, of course, it's always a case-by-case basis, but it's important to announce and establish the diagnosis for several reasons. Who should we inform? Ethically, the patient should be informed, but there are different cases. If it's a very severe stage of dementia, maybe it's not very interesting to tell the patients that they have Alzheimer's disease. But I think from the very early stage, in the prodromal stage, patients should be involved, and the stakes should be explained to the patients because there might be decisions related to that. The second question, or the second aspect of the answer is usually I tend to inform families. Families are an essential partner in the disease management in the long term. So telling the patient, unless it's a severe stage, otherwise inform the family and explain what is at stake. Work together. Families should be very much aware of the consequences of the disease for the patient. It's important to establish a diagnosis. Why is that? Over the years, we've realized that it was important, and I'm not so young now, I'm quite experienced, and a few years ago, patients who hadn't been identified arrived at hospital in a very poor state. And for a few years now, we have improved the management and we have better diagnosed the disease, and it has fundamentally changed how this disease is managed. From a very early stage, patients can be involved in the management of their own disease, and we can anticipate difficulties that will arise. So at the beginning, involving patients is just a normal, traditional relationship that you have with your patients, and then little by little, you involve the family a bit more. We also assess a number of criteria, like the fatigue linked to the disease, and we continue involving the family in order to make sure that the patient can remain in their home as long as possible. That's what the public healthcare system has decided over the years, to inform the patient, involve the families, and we can see that it has had positive impacts because patients live a lot longer now and in a better state. And the last question was about slowing the progression of the disease. With a diagnosis, you can administer drugs or non-drug interventions. Of course, there are not so many treatments, people might say, but it's not true. There are anti-cholesteric treatments, and we consider that these treatments show some efficacy. It is limited, but it is still very interesting. For people with behavioral disorders, there are specific drugs and also non-drug treatments, cognitive stimulation, patient management in different ways. There are many possibilities to support patients, so it's absolutely essential to identify patients with AD as early as possible, because then they are better involved in their healthcare pathway, and it's better to meet their needs and answer their needs. The videos that will be made available tomorrow in all the different countries, you will find solutions that are adapted to every country. So every country will publish videos. Thank you, Professor Dubois. The third question for Professor Piau: what type of activities can be proposed to a person with Alzheimer's disease? Well, I think we should make a distinction between, first, domestic and social activities. Nursing homes, they are places where people live more than they're treated. So we should have daily activities, also talk about their memories, their past, their history, make sure they're involved. And we should also emphasize the importance of these people and make sure that they become, that they have social activities. The main objective is to preserve their independence, whether functional or cognitive, and so cognitive stimulation is a very example of what we can organize. There's also another field, which is non-drug intervention. Non-drug intervention, what is it? It's very targeted. It's indicated, such as a medication would be. So it is an intervention that is indicated, that is administered. We assess the observance of the patients. That's why it's different from social activity that is more general, but they come together and both are essential for people with Alzheimer's disease. And non-drug interventions are very important in what we do. Fourth question about eating habits. I think, Professor Piau, you can also answer this question. Eating is one of the activities that Alzheimer's disease can make difficult. People with AD often lose weight very quickly, and this usually happens because they actually forget to eat, or they are convinced that they've already eaten. How can we manage this specific issue? Professor Dubois and I know very well that undernutrition is a major problem related to Alzheimer's disease because it leads to full immunodepression, low immunity, and thus infection. So what our nursing staff can do is adapt. They do that very well. So for instance, they adapt the texture of the food. They suggest snacks. Eat whatever you want, whenever you want. So that's good news. And we also we have non-restrictive diets. People can eat savory things or sugar because they enhance taste. And so we're really, it's not about making sure that they eat healthy, but that they also like what they eat. It's also important to make sure that people can eat with their fingers, handheld meals, instead of using cutlery. And if people can eat on their own, it's always good to let them eat and instead of giving them food, because this can have negative consequences. So again, that's case-per-case basis. It's very customized. And it's also important to monitor weight. Also, sometimes we prescribe nutritional supplements, but that comes in a second stage. First, common sense, adapt food and meals, and then comes the medical aspect and finding the right balance between a place where people get healthcare and where people live. If I may, I'd like to add one point. There are drugs that are still being prescribed for AD patients, but they can lead to weight loss and anorexia. So we need to be very careful with anticholinergic treatment, because this can lead to severe weight loss. So we make sure we monitor weight very closely. Thank you very much for this clarification. Now, question about caregivers and families. When caring for someone with Alzheimer's disease, one of the biggest challenges is to manage daily life. What are the suggestions for easing the burden on families? That's a major topic. We could talk about it for hours, but I will try and be brief. First, we need to acknowledge that it is a burden. For caregivers, it is now mostly recognized, but there is also a burden for healthcare professionals. It is difficult to support people with cognitive disorders or psychiatric disorders. That's why we need trained people, and we need to train them and to exchange practices. We need to recognize that the nursing staff should be supported and all year round, not just during the Alzheimer's Awareness Month. Second thing, we need to anticipate. As you've described, Professor Dubois, in the past we had horrible situations with people that were underdiagnosed with major behavioral disorders, staff that was exhausted and sometimes hospitalized, and with a severe impact on family life. And today we can avoid this with early diagnosis, with informed consent, with transition stages, where the patients are at home, but also daycare, so caregivers can get some relief. So first, recognize that it's difficult, and second, anticipate and diagnose as early as possible. I've also noted something that is quite interesting, says Professor Dubois. In many cases, caregivers complain, or nursing staff complain, that their patients experience apathy. Apathy, so they don't do much, they don't want to get treatment, but it's something that families don't really like. They say, well, you know, in the past this person was very dynamic and now they don't want to do anything, and they associate that with depression, which is not the case. Apathy is a symptom that is directly related to the disease by a damage of structures, or the structure of the motivation to act. So it's not a consequence of depression, but it's a direct consequence of the disease, and people should be aware of that. If the person doesn't do anything, we need to accept that. And stimulation, excessive stimulation, is not necessary in this case because the person doesn't want to do much, so let them be. And maybe it can provide you with some relief as well at the same time. We also mentioned people who wander in our units, and apathy in this case, you may describe it. Yes, it's the fact that patients, and families complain about that, patients stay for a few minutes or hours on a chair in the afternoon without doing anything, whereas in the past they behaved in a normal fashion. So that's a new type of behavior, but it's the consequence of the disease in the forebrain. So sometimes it's a warning symptom, a warning sign of the disease, but it shouldn't be associated to a depression necessarily. So you should ask the person, you know, as a doctor, I do that myself. I ask my patients if they're unhappy. No, they're not unhappy. They don't want to do anything. And you can tell the patients to do something. You can walk with them, and then they are motivated, but they are not spontaneously. They don't spontaneously do that. People with behavioral disorders, they get agitated, they move in an uncontrolled fashion. That's another symptom of the disease. It's a very odd disease, actually, because the manifestations, the signs from one patient to another vary greatly. Yes, sometimes we see patients wandering at the... It's called sundowning, so at the end of the day, because the light is different. So when the sun goes down, it's a time of the day that is... that patients don't like so much. So sometimes you can give certain drugs at the end of the day to combat anxiety. Yeah, anxiety at the end of the day when the sun goes down, it is a real problem. So anticipating this issue and asking the families if it's difficult at the end of the day, and they say yes, we should then tell them yes, of course it's related to the disease, and so they understand better what's happening to them. Last question, unless there are other questions in the chat box. For you, Bruno, how can we behave with Alzheimer's patients? What are the good practices, right tools, or habits? Well, it's difficult question. It depends on the situation. We should have a physical interaction with the patients, not just verbal. Be very kind, touching the patient, relieving the patients, diminishing anxiety by being close physically to the patient. Also, routine is important, daily routines, simplifying the environment. there are many different things, many different tools and habits that work quite well in this situation. But the best tip I could give is avoid being in conflict for things that are not important. If the patient says that they've seen their mother in the morning when their mother died 20 years ago, it's useless to tell them that they haven't seen this person. Don't try to establish the truth every time. You shouldn't think that you will help them by doing so. It's their own rationale at the time, and the consequence of being in conflict is that they will withdraw, because then they will think that every time they say something, they are being contradicted. So in that situation, the patient will withdraw and stop interacting, and they will develop, they will become more aggressive. And, the families should not be rational in that case, not try to establish the truth. Absolutely, says Professor Piau, and professors do that very well. They can distract patients. Yes, that's a good message for professionals and nursing staff here. Antoine, last question. In certain cases, are long-term facility cares for patients, is it advisable? Is it good for people with Alzheimer's disease? We often hear that Spanish people, Italian people, when they are elderly, they don't want to go to long-term facility cares. But people should understand that there are very different units. There's daycare, there's long-term facility care, there's adapted care, and for patients at every stage of their life, there are units that are suited to their needs. And with patients that have difficulties at night, or with families that are exhausted, it might be the good solution, and we need to anticipate that. And we see that with families, the burden of the care relies on one brother of the family that is not supported by the rest of the family, and this leads to tragic situations at home. So I think we have a wide-ranging offer. It's not just long-term facility care, and we want to have more and more activities in our units on top of expert care without being a hospital. This is a place where people live. We don't want to be too simplistic because that's not helpful. It doesn't help caregivers, it doesn't help patients. So in certain cases, yes, long-term facility care is a good solution, and this should be suggested at the right time. Thank you very much. I suggest now that we stop our Q&A session, and maybe we can give some time to Antoine to close our session. Thank you very much for accepting the challenge meeting on this meeting on Alzheimer's disease. I would like to thank the whole network, all the staff that was mobilized today and that logged on and that are very busy for this Alzheimer's weekend throughout the year. Thank you very much. Antoine, a word to conclude?
Merci beaucoup.
Of course, thank you so much. Thank you to everyone who made this event possible. The Clariane group has a completely adapting offering for patients with AD. Secured units, day beds, long-term facilities. But of course, we do not just treat Alzheimer's. We take care of all neurodegenerative pathologies, and we can also take care, more generally speaking, of all vulnerable people. And that's what we mean by positive care. We we care for people. We're here to care for people, care before healthcare. And our first objective, of course, is to maintain function. So functional autonomy, cognitive autonomy, nutrition, morale, so on and so forth. And third point, non-drug therapy. Do no harm first. So you want to limit psychotropic drugs, although sometimes they're essential. So you want to pay attention to your patient's life quality of life. And then you want to exchange practices as well. Best practices sharing is very important. And here I'm not saying that local initiatives should be done away with. Quite the contrary. They should be shared with the rest of the group so that we can do better year after year. And actually, teams are very creative. Sometimes they call upon pets. They might use new technologies as well when that is relevant. So I believe that we need both. You want to call upon the benefits of the group and encourage local initiatives. And to conclude, I wanted to thank everyone again, and most of all of our teams in the field who are engaged on a daily basis to care for people with neurodegenerative diseases and Alzheimer's in particular, and all vulnerable people. Thank you, everyone. Goodbye.